Where are you going to set up? I'm going to record from the table.
Thank you very much. My name's Louise Irvine, and I'm the co-chair of the Clinical Advisory Network on Sex and Gender, which we call CANSG for short. Not a great name, but that's what we call it. And my co-chair, Stella Kinga, is sitting here in the front row there. And we have several members of CANSG here in the conference, as well, of course, as the wonderful Stella O'Malley, who's a member of our group. And that shows some of the collaborative work that we are able as a group to do with other organizations. There's quite a lot of overlap. I'm a general practitioner, a GP. I don't know if you all know what that is. It's probably in America, you might call it a family practitioner or a primary care practitioner. And I live in London. So I thought, well, the title of the talk is How Clinicians Can Challenge the Prevailing Orthodoxy of Gender-Affirmative Medicine. And the short answer is, it's difficult, but it's possible. And we have made some positive changes, and there's still an awful lot more to go. I thought the best way to talk about this would be just to talk about how the group formed, the challenges it faces, what we've managed to achieve so far, and what our plans are for the future. And in so doing, I hope it may inspire those of you from other countries that may not have a clinicians group to think about ways that you could organize. I believe there are people from about 15 different countries here. So I hope that what I talk about gives you some ideas and some inspiration. Naturally, it's very tied to the situation in the UK, the way we organize medicine and healthcare in the UK, and it may not all be exactly applicable in other countries, but there should hopefully be some things that you can take from it. And I should also say, I mean, the UK is complicated. It's called the United Kingdom because it's actually got four nations in the UK. There's England, Scotland, Wales, and Northern Ireland, and they all have slightly different healthcare systems and political systems and regulatory systems. So our organisation contains clinicians from across the UK, and we also have some clinicians from the Republic of Ireland, which of course has a completely different healthcare system. So most of what I'm going to talk about is about England, but with relevance to some of the other nations in the UK. On language. It made me think quite a lot yesterday, on terminology, and I realized I was using in my talk, all kinds of words. I was talking about gender incongruence, gender distress, gender questioning. I try to use some of the language that's in the Cass Review because she uses that language of gender dysphoria, gender incongruence, gender questioning, gender distressed. But I did like Stephen Levine's idea of currently transgender identified, and I think I might try using that more. Why form a clinicians group? As the numbers of trans-identified people, especially children and young people, presenting to professionals with gender-related distress and seeking referral for medical treatment grew, so did the questions and doubts of those clinicians who were encountering them and trying to help them. And I do resonate with what people said. We're trying to help people who present to us in distress. So whatever the reasons or the causes, we are sitting there in front of somebody who's saying, I'm distressed, I need help. And our impulse is that we want to help. So this can happen whether it's in primary care, mental health services, or specialized services. What the clinicians who formed our group and who have been joining it have been disturbed by is the gap between the care they're expected to provide for people who identified as transgender and the evidence base for the treatments that we were expected to use, specifically the gender-affirmative approach. We were alarmed by the dearth of evidence and the seeming lack of concern amongst medical authorities about this. The exceptionalism of the approach to gender medicine was remarkable. It seemed nothing had been learned from previous medical scandals where life-changing interventions were embarked upon without evidence of safety or benefit. There seemed to be no real interest in the whole issue of child safeguarding, which suddenly seemed to be thrown out the window when it came to children and young people. And we were all schooled in the principles of evidence-based medicine, and although I know a lot of medicine isn't as evidence-based as it should be, but that is our goal, that is our aim, that we should have evidence to support. And what we're doing, and the more drastic the interventions we're doing, the more evidence we should have that it's safe and that it's effective and that on balance it does more good than harm. But that wasn't. We found that didn't exist. And there was no forum where we could discuss these concerns. And any attempt that we did to try to raise it in our professional bodies or just amongst colleagues was shut down with accusations of bigotry and transphobia that quickly, I've spoken to quite a lot of clinicians who have said they just felt completely silenced by this and they didn't dare raise it ever again. In addition, when our group was formed a few years ago, it was part of a general wider cultural context. There was the socio-cultural takeover by trans ideology of medicine and healthcare institutions. And this had huge impact on things like service provision, for example, loss of single-sex services for women, the rejection of the material reality of sex, changes to language, such as the erasure of the word woman and mother, and the replacement of the concept of sex with gender, which had huge implications for data collection, research, medical records, and medical education. It seems, just talking about the issue of women and language, it does seem remarkable that barely 3 decades after it was recognized that clinical researchers had to acknowledge the important sex differences between women and men and finally include women in research in order to better understand women's specific health issues and health needs, the medical scientific establishment seemed all too happy to erase women again. So we have main focus is on gender-affirmative care, especially for children and young people, but we also have the wider concerns that I mentioned there. We were facing the almost total ideological capture of most of the institutions in the UK, not just the medical ones, but also political parties, the civil service, universities, charities, the law, the police, sports authorities, everywhere you looked. Within medicine, every single institution had bought into gender ideology, from the state organisations such as the Department of Health and NHS England, Wales and Scotland, to medical schools, royal colleges, professional bodies, health unions, professional regulators, and inspection bodies. This didn't just happen by chance, but through at least 2 decades of infiltration into decision-making structures by trans activists who were very well organised and determined. And we should take a leaf out of their book, really. They've been very good at it. We've learned that if you want to roll back any of this, or indeed have any influence or change anything, you have to be organised. And that's why we got organised. So, these are our aims. Any group must have clear aims, especially one that's taking on such a wide-ranging set of problems, because otherwise it's impossible to stay focused and not be pulled in all different directions. And we try to make our aims broad enough to cover the scope of what we thought a clinical group should do, and narrow enough to be able to focus on how we could be most effective. There are many other groups doing great work with whom we collaborate, so that each group can play to its strengths, supporting each other where our interests coincide. We can't do everything, but thank goodness we've got other clinical groups we work with. There's SEGM, there's Genspect, there's Transgender Trend, there's Thoughtful Therapists, there's other groups taking up the wider issues like Sex Matters, like the Women's Health Network and the women's group within that, and we've got a sister organisation in Scotland called ScotPag. So that's how we do it. We collaborate. We can't do everything. We try and do what we specifically can do. So what have we been doing? Well, it's quite a lot, really. And I think it boils down to 3 broad categories. Firstly, to fellow clinicians, to try to inform, support, and include them in dialogue and discussion. Secondly, to politicians and policymakers to try to both influence them and provide the necessary alternative narrative and perspectives to the ones they're exposed to by their very well-organised trans lobby groups. And thirdly, the provision of information to members of the public. And some of us are working, we work as a whole group, and sometimes we work as individuals in our Royal Colleges, our professional bodies. Some of us are doing research, some of us involved in training. One of the things we're most proud of is our conference we held in March 24, First Do No Harm. First and only conference of its kind in the UK to address these issues, and so far there's been no others. Professor Rita Kurtu-Kaltiala was our keynote speaker. And we talked about everything. We talked about gender-affirming care. We talked about alternatives. To that care, we talked about what was happening to children and young people, detransitioners, the caste review, what was happening in schools. It was horribly attacked by activists. And you probably saw, some of you may have seen some videos. And even the Royal College of General Practitioners, we'd booked their conference venue, and they tried to cancel us. They tried to disown us, and they tried to say, they kind of played along with the idea that we were all bigots and transphobes and conversion therapists. And then we were attacked. It was the most vicious and violent attack on any conference I've heard from people who organise such things. It was fine. We were on the 5th floor, and we had great security, and it was sorted, and most of the conference went blithely on, enjoying the opportunity. But we have to still remember that there is still a price to be paid for speaking out. There's a cost to speaking out on this issue. There's a cost for all of us. There are threats to our livelihoods. Many of our members have been reported to and complained to their employers, to the General Medical Council, and have been accused publicly of being transphobic, bigoted conversion therapists. So it's hard. It's not super easy. It's getting a bit better. We're getting stronger, but it's still quite hard. So that's some photographs of our conference. And so, positive changes that happened, not all because of us, I hasten to add, but I think we contributed a little bit to some of those changes. And I won't go into detail because I don't have enough time, and you probably know quite a lot about it, but the closure of the Tavistock JIDS was hugely important. And it was the single service in England and Wales for gender questioning and distressed children and young people with a satellite clinic in Leeds. Staff began to raise concerns about it in 2005, but were ignored. Again, around 2018, further staff concerns raised, leading to critical reports, news coverage, a court case that exposed profound flaws in the service, another court case that exposed safeguarding failings, a failed Care Quality Commission inspection, and finally the decision that it should close, which it did this year. Certain names stand out that we should honour and thank: Sue Evans, David Bell, Kira Bell, Sonia Appleby, and the amazing journalist who brought this issue to a wider public, Hannah Barnes. As well as a great many other clinicians who risked censure, opprobrium, and loss of livelihood for saying what they believed to be right. Oops, I've gone too fast. This led to the caste review. We all know about the caste review, landmark review, amazing. I have a whole long spiel about it, which I'm going to cut because I don't need to say it. You know. And you know it was welcomed by leading medical bodies in the UK and internationally. It's reverberated around the world as an exemplar of the type of approach that should be taken to this area of care. No longer to treat it as some kind of exception to the expectation that if we are to make profound changes in children's lives, we must know why we're doing it and that we're likely to be doing more good than harm. That is the evidence-based approach, and one that should apply to all branches of medicine, including treatment of children and young people. Following on from that, we've got the ban in the UK on the use of puberty blockers, which means that they are no longer routinely prescribed. They can be still continued on for those children already on them after assessment, and they may be able to be prescribed under research conditions, but they're not routinely prescribed. Instead, we're going to be offering psychosocial interventions as first-line therapy. But also the government has brought in a ban on overseas and private prescribing of puberty blockers, which is just fantastic. And another great thing that came out of the caste review was a recommendation, and we've been told it's going to happen, it's happening, is now a review of adult services, because you probably know that research shows that something like 70% of the referrals to the adult services are people under the age of under the age of 25, and 75% of those are women. We're seeing the same cohort that we were seeing in the children's clinics now moving up into the young adult clinics, and the same complexity, mental health issues, other issues, and this needs to be properly reviewed. And also there are going to be services for detransitioners finally. We have to keep the pressure up for that. There's still, I won't talk about language and data on sex and gender. There is work being done on that issue. We have won over a lot of the Royal Colleges, which are the professional bodies that regulate professionals in the UK, have embraced and welcomed the caste review, with the singular exception of the British Medical Association, of which I'm a member. But I mean, you know, they have been, again, captured by a small group of gender zealots, and the BMA Council a couple of months ago voted to reject the caste review. Most of them, I don't think any of them had actually read it. And then under pressure, they said they would do their own evaluation of the caste review. In 4 months, they were going to evaluate something that took 4 years and had 7 systematic reviews, but okay. But then we pointed out, and we said, you can't evaluate something neutrally that you've already rejected, because that doesn't make any kind of sense. Anyway, I helped to organize a letter which just went viral and was signed by 1,500 doctors, including 1,000 BMA members. And, this got amazing press coverage. Hannah Barnes again stepped up, but it also started, it was covered by the BBC, the Times, the Telegraph, the BMJ, the Lancet. So it was not going away. 2 months after that vote, it was still it was still in the news. So under pressure, the BMA Council, just the other day on Wednesday, changed its mind and decided that it was no longer going to oppose the caste review because it was doing an evaluation. So it was going to wait and evaluate it. So good. But the only good thing that's come from that, first of all, it's really embarrassing to the BMA, which I think is good. You know, they've been shamed in the court of public opinion. But also, now you're not going to get people going around saying, oh, BMA represents the voice of British doctors, and British doctors are opposed to caste. And we were beginning to hear that being said in this country, in the UK, and also internationally. But that cannot be said anymore. We've got a long time lot more to do. We've got to make sure caste is properly implemented. That needs proper funding, investment, and the NHS is in dire straits at the moment financially, but it also needs proper staffing. There are big problems ahead to actually make caste really work. They're talking about doing research into puberty blockers. We're a bit worried about that. We're going to have to see what the research is. Can you ethically do any kind of really good ethical research on puberty blockers? Question mark. We're going to be intervening on that question. There's still the school to clinic pipeline, and we work along with other groups that take up this issue of schools doing the social transitioning. A lot of schools are not sure what to do. There's been some good government guidance came out in the last government, and now this one is carrying it on. But there are still flaws and there are still problems there. So that's another area. And then finally, we've got to face the conversion practices ban, which the Labour government has promised it will bring in. And we know that one of the aims of these conversion practices bans is to undermine exploratory psychotherapy, CAS-aligned therapeutic approach, and reassert gender-affirming medical interventions. This is really the subplot behind the push internationally for these conversion practices bans. So we have opposed previous bills that were brought in by previous governments, and we've given evidence. We've been called to give evidence, which has been great. And of course, we're going to have to step up and do that in the coming months. And finally, looking to the future, we're trying to develop our role as a resource for information, a kind of go-to resource for information and advice to policymakers, clinicians, public, and patients. We're not very well known yet. We're trying to get more well known. We've got a website, newsletter, etc. I think there was a QR code in my first slide, which takes you to our website. We've got this big role to support our members. It's really very, very hard still, and many of them still feel very isolated. And all we're trying to do is open up opportunities for dialogue and discussion on the issues of sex and gender. Combating institutional capture is an ongoing project. It's just like pulling yourself up a mountainside and it's massive effort. You've made a tiny bit of progress, but you're still making some progress. And reinstating sex as an important concept in science and healthcare is the big challenge, because it underpins both of those different aspects I talked about earlier. One, to do with gender-affirmative care, the idea that you can change sex, or etc., but also the wider issues impacting our understanding of men and women and our healthcare needs, which we do have to make progress on as well. So there's a huge amount of work. We're tiny and we don't have any resources. And if anybody wants to show support for us, please donate to the group, and please find other ways that you can support us, because we've got an awful lot to do. Thank you.